by Britam Health. Britam Health offers solutions to our corporate and microinsurance clients, and specifically our wellness department focuses on giving health solutions to our clients to improve their quality of life through disease prevention and health promotion. With us today is Dr. Peter Waweru Munyu, who will be discussing asthma facts to us. And we also have our sign language, Nelly Chepkemoi Langat. She's a sign language interpreter. She'll be joining us shortly. First and foremost, I would like to apologize for the 13 minutes delay. But now that we are in and ready to go, I will go ahead and introduce our speaker. Dr. Waweru Munyu is a chest physician and a pulmonologist. He's been in practice for almost 10 years now, and he will be breaking down the asthma facts to us today and telling us that truly asthma is treatable and it can be controlled. So without further ado, I welcome you, Dr. Waweru. Karibu sana.
Thank you, and I hope all of you can hear me. Good morning. And I would like to thank the Britam team for inviting me to talk about this very, very common condition. It is a personal condition, and as you go along, you'll know why it is personal to me from the examples that I give. There are many things related to asthma that many people appreciate, but there are also a few things that people do not understand, and there are very many questions, and whenever there are questions which people don't understand, myths and legends come up, and some of these myths are propagated over time, and people end up not getting the right care for a condition that is easily manageable, a condition that can actually kill you, is managed so well that you can achieve anything you'd like in your life. So as we discuss asthma, we need to ask ourselves, what is this disease? And I would like to define it according to one of the large bodies in the world which look at asthma and write guidelines about asthma management. These are the GINA guidelines. And the GINA guidelines define asthma as a condition which is heterogeneous, and it's usually characterized by chronic airway inflammation. And this condition is defined by a history of respiratory symptoms, such as wheezing, shortness of breath, chest tightness, and cough. And these systems vary over time, and they also vary in intensity. And when we do some tests, we can demonstrate that there is expiratory airflow limitation. You can see that I have highlighted a few words, that is heterogeneous, chronic airway inflammation, and expiratory airflow limitation. So what are these things? That's what that fellow is asking. Let's go through each of these things. Heterogeneity basically means that this condition doesn't like looking the same all the time. It is a fashionista of diseases in that it will manifest differently in different people. That is why you'll find some people only cough, other people only wheeze, other people only get short of breath, but there are also people who get different different manifestations of those conditions in their asthma history. The same thing happens within the individual, in that you may find, for example, through a lifetime, a child is born, and when they are young, the main thing they do is cough and wheeze. As they grow older, maybe the age of 7, 8, 9, these symptoms may disappear completely, only to emerge later. And when these symptoms emerge later, you may find that this person stops wheezing and they may just present with a long-standing recurrent cough. Or they may not cough and they only have shortness of breath. So this disease has a characteristic of changing. The symptoms that you get in this disease change over time and within the individual and between individuals. The second aspect has to do with chronic airway inflammation. Sorry. I think we are projecting the wrong one. Let me see if I can get my slides back.
As Daktari gets the slides back, kindly I'd like to add.
Here we are.
Please
Here we are.
questions in the chat box.
Yeah. The second thing we talk about is the chronic airway inflammation. And chronic in the medical terms stands for long-standing. So this is a disease which you disturb a person over many years or even sometimes over a lifetime. The airway is that part that carries air from the nose, tip of the nose, up to the lungs. Remember, the airway has different parts. There is the nose, the throat, the airway that is the trachea, the bronchi, and all these things are affected in those patients who have got asthma. And even when we manage this condition, we need to take care of those other parts which are not routinely what you'd call the lung. And then when you talk about inflammation, this is a reaction to something. And this something in a person who has asthma is either internal or external. When you talk about external triggers of asthma, we are talking about things like dust, cold air, and so on. And then on the internal, here we are talking about people who have problems like acidity, emotional problems. For example, there are people who, when they get stressed, their asthma symptoms manifest more. Or when they get depressed or when they are so happy, the asthma symptoms manifest a bit more. And then the third thing I had highlighted is the expiratory airflow limitation. This is a manifestation of the airway where, because of long-standing inflammation, two things happen. The first thing is that the airway goes into a spasm, and therefore air cannot pass in or out adequately. The second thing is that with long-standing airway irritation or inflammation, the lining of the airway gets a bit thickened. And you can imagine if you have a tube and that tube gets thickened, it can reduce the lumen, and that therefore will cause a reduction in flow of fluid, or in this case, the flow of air when one tries to breathe in or out. So having discussed about what asthma is, how common is it? Why is it a problem? When we look at the data globally, yes, sorry?
We still can't see your slides. Kindly try and reshare your slides.
Okay, let me try that.
I see some questions coming in. Thank you, Pavel. Thank you, Joyce. Please keep the questions coming in through the chat box. Also, you can do same at the YouTube and Facebook comments. We will still tackle the questions at the end.
Yeah, it's indicating that the host disabled participant screen sharing. So please allow me to share.
Wakati hiyo mama alinitumia hiyo message.
Let me try to share again.
Thank you. We can now see your slides.
Thank you too. So I was saying that, just to recap, that asthma is a heterogeneous condition which varies over time within the individual and between people. It is mainly driven by long-standing inflammation or chronic inflammation, and this chronic inflammation causes narrowing of the airway. And how common, therefore, is this condition? In 2016, the worldwide figures were showing that there was about 340 million people affected by asthma. That's a huge number. 2 years ago in this country, we estimated that there were 4 million people. That's about 10% of the people in this country having asthma. So why don't we see these people coming up and getting treated? The thing with asthma is that it's a variable condition, in that it will disturb a person at a period of time, stop, disturb that person again, stop. And the other thing is that majority of people who have got asthma have the relatively milder forms of asthma. So you'll see this child who doesn't like playing with the others, because whenever he tries to play football or other games, they get very short of breath, or they get chest pain, or they start coughing and they stop. Or this person whom you're always telling, please go and do exercise, but they cannot do, because whenever they stand on that treadmill or they are running in their compound, they get so short of breath. And sometimes it can be so severe that one feels like they will die. There was a study done between 1995 and 2001 in this country, and they were basically looking at children in Eldoret and Kericho. And what those studies showed were two things: that in children who are between 13 and 14 years old, at least 10% of them were affected by asthma in 2016. So if you went into any class in this country of 13 to 14 years, this may be standard 8 or form 1, but this will change over time, you'll find that 4 of those children will have asthma. But unless they have severe asthma, most of them will be missed. When this study was looked at again in 2001, the number had increased. And there are certain explanations for this. One of them being that when people live in very clean environment, their immune systems tend to sometimes misbehave. It tends to recognize some things which are normal as abnormal. So reacting too vigorously and therefore causing asthma. As you can see, the number in Nairobi is quite high, 18%. That means almost every 2 out of 5 children have something to suggest asthma. And these are our children, for those of us who are living around here. So looking at it worldwide, you can see that we are not doing so badly, but these are natural things. Like in Australia, you can see that the numbers are very high. Also in Europe, UK, we fall in the maybe moderate group, and therefore it is still a problem for us. And we need to be aware of this so that we can manage ourselves. So when we are so much worried about asthma, we know many people are very, very scared about asthma. What do we, how does it affect our life? And does it need to affect our life? What I'm going to show you is that although asthma is feared, asthma can interfere with people's lives. We can also live a full life. So now, for those of you watching and they love football, who can tell me who is the person on the right side of, is it the left side of your screen? Just to give you a hint, this is a gentleman from UK. He played in all the good leagues. He played in the UK league, the Premier League. He played for Real Madrid. He played in the World Cup. He played in France with Paris Saint-Germain. So this fellow, despite having asthma, was able to reach the highest levels of footballing world. And even now, as he continues with his life, because he's still playing, he went on to play in America. By now, I am sure those people who are interested in football know who this is. This is Beckham. For the ladies, this gentleman married Spice. You remember?
Hello, Daktari. We seem to have lost your audio.
Can you hear me?
Yes, we can hear you now. Thank you.
Okay. Yeah, so the second gentleman is a swimmer. Many parents fear when their children are diagnosed to have asthma, that, oh, my child can never swim now. And you know, swimming is a very healthy habit. I would like to tell you that this guy was he won 6 gold medals. Indeed, in one of the Olympics, he won 2 gold medals. That is a 100 medley and 200 medley swimming competition. That is Olympics. So he was also doing sports at a very high level. And therefore, even if one has got asthma, one can still do all those things that they like. but they need to do a few things. They need to get proper diagnosis and proper treatment. This is another group of people who have also done very well. The football people, the football fans can, of course, identify that gentleman there. He's called Frank Lampard. He's a very, very prolific footballer. And for the ladies who think that it's only the men who are doing very well, there's that lady called Paula Radcliffe, who also won the Boston Marathon. He won many other marathons. So really, you don't need to stop your life just because asthma is in the picture. And this is a gentleman who used to show Kenyan dusts. He was called Gabriele Selassie. He still runs, but now not competitively. And he's one of the worldwide asthma ambassadors. And you can see our Kenyan friend there has done his best, but Gabriele Selassie is lifting his hands up in glory, having won that marathon. So as far as asthma is concerned, you can still do much, much more than what the disease allows you to do by getting proper treatment. We move away from sports. We all know that American president, Bill Clinton. He was a very brilliant lawyer, still is, and he led the biggest economy by that time. And we do know that he has asthma, but it is well controlled. When you think about going into the bush, if you like going into the bush watching animals, there is that gentleman at the next there. He's called Che Guevara. He was a bushman in terms of freedom fighter in South America. So he spent most of his time in the bushes. So if you like nature, you have an example there that asthma does not need to stop you, even if your lifestyle is an outside world lifestyle. And even for those people who like other things, the music that was playing belongs to those that gentleman. He's called Coolio, also a very successful musician. So really, if one has asthma and it is properly diagnosed, properly managed, and properly treated, we should be able to achieve all that we need to achieve in our lives. Let's go on with a little bit hard stuff. So where does asthma come from? Simply put, asthma is a situation where the body recognizes strange things and reacts excessively. As you can see on the right side, there is something there written antigen. Antigen is one of those compounds we find in the air especially, or even in food, that gets into our body. It is picked by the defense cells. There it is called a dendritic cell, and through a certain cycle leads to inflammation. Inflammation is a reaction of the body to something else, and there are multiple cells which are involved in this process, and I will not bore you with them. Suffice to say that if we are thinking of managing asthma, we have to have in our mind all these cells, and we have to know that they are going to drive this process. And when we are treating the patient, we need to sort out this process. You will notice that there is no bacteria there. You'll notice there is no virus there. And therefore, even as we treat these patients who have asthma, antibiotics do not have a role at all in treating these patients. There are many people who will use antihistamines. As you can see, the cell which produces histamine in large quantities is called a mast cell. It is only one of those cells that is involved in this process. And histamine is only one of the chemicals involved in this process. As you can see, it's a very complex process. Therefore, just using a simple antihistamine will not be enough. So, to look at it simply, one, there's the issue of genetics, and this is not straightforward genetics that I'm African, my children are most likely going to be dark-skinned. No. There's a huge interaction amongst the different parts of the immune system, and that is why you find sometimes you find a family, let's say a family of 6. There is one person who has asthma. All the others do not have asthma. Alternatively, you may find a person developing asthma even when there is no family history, even the uncles, the aunties, none of them has asthma, because there is an interaction between the internal immune system and the environmental trigger. Environmental triggers are those things that lead to this reaction. And some people may be exposed to certain environmental triggers at certain points in their lives, and they end up developing asthma. So it does not always count that I have no person in my family with asthma, therefore this cannot be asthma. We need to be open to that knowledge. Then we look at those things that can trigger asthma. We start with smoke, and this smoke is either industrial smoke or tobacco smoke. These days, a lot of people are using weed, so even weed smoke. And for parents, it is very, very important for us for those people who are smoking, it is very, very important to recognize that in our children, asthma can be triggered by cigarette or other types of smoke. And therefore, for us to be able to to prevent them from getting those severe attacks, we may need to quit that habit of smoking. The other things like emotions, as I had mentioned earlier, some people get very happy. Your child graduated the other day and you're very happy, you get an attack. Pets, especially those which have fur, can also trigger attacks in some people. Colds, and I need to mention something about colds. Asthma does not only affect the lungs, it also affects the nose and the sinuses. And therefore, there are people who develop asthma symptoms and they will come and say, Daktari, I have had a cold for 3 weeks or for 4 weeks or for 5 weeks. Generally, when doctors look at a cold, this is a viral infection. And usually within 4 to 5 days, in most people, it has cleared. So if a person or your child or your relative develops a cold, which hangs on and hangs on for many days, maybe more than a week or so, one needs to assess whether this is a real cold or it is an allergic reaction, which is a precursor to asthma. So using antihistamines in this case may be indicated if one is having an allergic reaction, while if one is having just a viral infection, they may not help much. We had already talked about exercise. There are some people who run and they get exercise, they stand on the treadmill, they get asthmatic attacks. And for this, especially if they are obese, it's important to have their asthma well controlled so that they can lose weight. There are other toxins in the environment, like parts of cockroaches. Food allergies may also trigger attacks in some people, especially in children when they eat proteins or even they eat avocados. Things which everyone else enjoys can trigger asthma in those people who are predisposed to have asthma. Cold weather, as we have heard over the last few weeks, also triggers asthma. But remember, as we mentioned earlier, asthma is different between one person and the next. And you may find that a person lives in Limuru, one of the coldest areas in this country, and they never have an asthmatic attack until they are employed in industrial area where they're exposed to certain industrial chemicals and they develop asthma. So cold weather is important, but not every asthmatic is affected by cold weather. When we talk about asthma triggers, we have to look at those which we can get rid of. We have already talked about smoking. We've talked about pets. There are people in whom we advise to stop keeping certain types of pets. If one is getting recurrent viral infections, we can recommend that they get vaccinated against the viruses. You are all aware about the influenza virus, the COVID virus, and so on. In terms of food allergies, and specifically in children, taking a very good history to know what the child reacts to is important. And there are also specific skin tests which can be done to identify the type of allergy a child or even an adult is allergic to. And if those are removed from the diet, then the person's asthma can be better controlled. When you talk about dust, especially in this town where some parts are always under the areas where construction is always ongoing, what we would advise is that damp dusting, when you're cleaning your house, you do damp dusting. It's better so that you don't get the dust floating everywhere and triggering asthma in people. Polish, paints, and perfumes are Ps which are strong and frequent triggers for asthma in some people. So what are the warning signs and what are the symptoms of asthma? The common symptoms of asthma are chest tightness, and this can be so bad as a person to start thinking that they are having a heart attack. Coughing, and this coughing can be at any time, but it is particularly annoying at night, and you'll find many people wake up between 2 and 4 in the morning, coughing, they can't sleep, and then during the day they are grumpy. Sometimes the bouts of cough are triggered by things like laughing or exercise. So when we take a history, those are some of the things that we ask for. Some people develop shortness of breath. And remember, this may be the only thing they manifest. They are just walking around, then they feel, I know I can't walk properly. I'm having a bit of shortness of breath. Sleep problems, especially caused by breathing issues. And remember, some of these sleep problems can be even those activities some people do when they sleep. There are some men or some women who cannot enjoy the family activities because they can't cope up. They are wheezing, they are coughing at night, and their partners can get very, very frustrated. Wheezing is one of the commonest symptoms for people who have asthma, and this is generally a whistling noise within the chest, which comes on when one is having an attack. It is not a must that a person has all these symptoms. A person may have some of these symptoms or even only one of these symptoms. For instance, there are people who have what we call cough variant asthma, and the only thing that these people do is cough. They never have a wheeze, they never have chest pain, but they'll tell you whenever I'm in certain places, I cough until sometimes they throw up, sometimes they can even faint. There are some warning signs which we need to be wary of, especially when one is known to have asthma. One, if a person develops a headache, because this may imply that they are having reduced oxygenation in their brain, and that really points towards a severe acute asthma. A stuffy or runny nose is just what we have discussed before, that asthma does not just affect the chest, it can also affect the nose, can affect the skin, can affect the intestinal system, the ears, so, and even the eyes. A sore throat can also be a manifestation of asthma. And there are many people who will come and tell you that I have been treated for tonsillitis 12 times this year. And it is very, very unusual to get 12 tonsillitis due to viruses or bacteria in the ear. So most times these people are found to have an allergic tendency. So if you find your child has had tonsillitis, or your partner or your friend has had tonsillitis 3-4 times, or they are getting recurrent sore throat, ask them to see a doctor, and also consider mentioning to the doctor to make sure that this is not asthma and or allergies. Difficulty in sleeping, we have already talked about. Because people are not sleeping well and they are also feeling uncomfortable, they may also become moody and irritable. And because they are not able to push adequate oxygen in their blood, they become weak and tired, especially during physical activities, which can be so severe that, especially in children, they cannot participate in activities like sports. In adults, you try to go to the gym because you want to shed a few kilos, you cannot because you are having a lot of difficulty in breathing and weakness. So this is meant to show that the airway is more than just the chest. You can see the nasal passage up there, and around that area you can see sinuses. There's the throat, there's the food pipe, which is just very next to the airway. It's called the esophagus, just next to the trachea if you look at the bottom of that picture. And sometimes we have acid coming up from the food pipe, and it irritates the throat. And because the lining of the food pipe, the lining of the throat, and the lining of the airway are continuous at that area, the inflammation also gets into the airway. And that is why it is important for those people who have asthma, but they also have acidity problems, or what we call gastroesophageal reflux disease. It is very, very important that these two conditions are managed simultaneously to get optimal outcomes. So manage the asthma properly, but don't forget to manage the sinusitis if the person has sinusitis, or to manage the rhinitis, that is the nose inflammation, or the food pipe inflammation, even as you manage the asthma. There are many, many diseases that affect, that interact with asthma. Commonly is the running nose, which may be allergic or non-allergic, and some people even develop growths within the nostrils, which are called polyps. And if these are not taken care of, then the person's asthma may never be properly managed. And the way we take care, we deal with rhinitis is by using certain medicines, which we call nasal spray steroids. They are steroids which are delivered as nasal sprays. Then there are patients who hyperventilate, and this is because they have a problem with the voice box. The voice box is connected to the airway, is the upper part of the airway. And sometimes when you have a problem in that area, the person may have recurrent inflammation of the airway. Then we have people who, as you noticed, have very, very labile emotional state. And these people have what we call psychopathologies. And as we have discussed before, there are people who will have either depression or anxiety, and they end up having an attack of asthma. There is a danger sometimes where people assume that, especially with young girls in high school, they get severe acute attacks. Indeed, last week on Sunday, I admitted a child like that. They were having severe acute attack. They were taken to a hospital nearby, and the person who saw them assumed that they had what he called hysteria. And this is a common misnomer. If that lady was not, a girl was not taken care of properly, we can end up losing that child. Smoking and nicotine dependence are other conditions which trigger asthma. So very, very important for those who smoke, they come for help, we stop them. There's a condition we call chronic obstructive pulmonary disease. This results either from certain genetic predisposition or from people who have been exposed to smoke for many years. This may be smokers or people who have lived in and worked in kitchens, especially our traditional kitchens, which do not have good airflow. Those people may end up with a condition of the airway similar to asthma, but slightly different. Respiratory infections like viruses can also cause asthma attacks to come down, to be triggered. An important aspect which is becoming even more important in our current world is obesity. Obesity is a lifestyle disease where people are excessively heavy, they have excess body weight, and obesity can make asthma worse. And therefore, for those people who are obese, we really advise them to try and lose some weight. And they can also end up with conditions like gastroesophageal reflux disease, which is acid flowing from the stomach into the airway. And as I've described previously, this can end up causing inflammation in the airway. Hormonal disturbances are also important in the following sense. Number one, there are women who only get attacks around the time of their periods, the what you call catamenial asthmatic attacks. And in this group of women, whenever they are approaching their period, they know they'll get an attack. So it is important we educate them that at around that time, they escalate the medication that they are using. There is also an interaction between pregnancy and asthma. We find that a third of women who have asthma get worsening of their asthma. But interestingly, a third of them have no change in their asthma state. And there's also the third which feel much better during their pregnancy. So you may not be able to predict how pregnancy will affect asthma. But most of the medicines we use for asthma are safe in pregnancy. And therefore, even when one has these asthmatic attacks, we have safe medicines which can bring them under condition. And finally, we talk about skin conditions which can be related to asthma, especially allergic skin reactions. Even when you treat asthma very well and you ignore the skin allergies, the same cells which are causing allergies on the skin will produce chemicals which can trigger asthma within the chest. So whenever one has one or more diseases that can affect asthma, those other diseases need to be properly managed so that the asthma can be nicely brought under control. So how do we make a diagnosis of asthma? Number one, and most importantly, is history. Indeed, a patient can give me a phone call and I listen to their story and I can say that, well, my friend, you have asthma, even before I see them. And the history is of those things that we have talked about, excessive reactions to certain things like smoke, perfume, paint, polish, and so on. Then we can do a physical exam. The importance of doing a physical exam is to make sure that this person does not have other conditions or conditions which can make asthma worse, or whatever this person is something not asthma, but is a disease which looks like asthma. Because remember, not all people who cough have asthma. Not all people who have chest tightness or chest pain have asthma. Not all people who have other manifestations, like, as we have discussed, like even shortness of breath, have asthma. So when we do an examination, we are trying to make sure that this is asthma and nothing but asthma. There are a few tests which we do. Many times people have complained, oh, I went to the hospital and I had a blood drawn, I had urine tests, I had sugar tests. All those tests are good, but in as far as asthma is concerned, there are two main tests that are done. The first one is called diagnostic spirometry. As you can see, that lady is assisting that gentleman to do the test. And what happens in this test is, if you remember, we had talked about airflow limitation. This machine is supposed to assess for airflow limitation. So we will ask the patient to take a deep breath and then blow out as hard and as fast as he can through this machine. And then the machine will generate certain graphs. And using those graphs, we can tell whether this person has airway obstruction or airway narrowing or not. Then we give that person a medication, wait for a bit of time, and repeat the test. When we repeat the test, we assess to see whether the airway has opened up. And if the airway opens up by a certain margin, then we can confidently say that this person has got asthma. For those places where they are not able to do this spirometry test, they can also use this next gadget, which is a simpler test, which we call a peak flow meter. This is a gadget where we ask the patient to blow as hard and as fast as they can, and then they get a reading of how much they have blown. And using those readings and also taking into consideration the size of the person in terms of the weight, the height, the age, the gender, and so on, we can assess whether this person has airway obstruction or narrowing of the airway or not. When we use a peak flow meter, we usually will ask the patient to check their peak flow rate, how well they are blowing in the morning and how well they are blowing in the evening. Because for a person who has asthma, there's an excessive variation of the amount of air that he can blow if you compare the morning and the evening. Once a person meets the criteria for asthma, then that person is managed for asthma. I had mentioned that asthma varies over time. And similarly, when we do these tests, sometimes we may do it when a person's asthma is quiet, and that test may become negative or may not demonstrate asthma. And that is why we go back to the history, so that even if this test is negative, does not show asthma, the history will be useful to help us determine whether indeed that person has asthma or not. There are many people who are suffering with asthma, but they have been told that their test was normal, and therefore they are not on the right treatment. So a history is very, very important. So when we have made a diagnosis of asthma, we then have to decide how to manage this patient. And if a patient, for example, is sent to me, the first step I'll do is to confirm the diagnosis by taking a good history, an examination, as well as doing the relevant tests, the two we have discussed before. And then I will need to exclude other diseases, which we call mimics. Mimics are diseases which look like and sometimes act like asthma, but are not really asthma. For example, there's a condition I had talked about called chronic obstructive pulmonary disease. This is a disease which results from long-standing exposure to smoke or dust or other chemicals. And the disease leads patients to wheeze, to have a cough, to have chest pain. And therefore, since the treatment is slightly different, I must confirm, is this COPD? Is this asthma? Then I treat the patient appropriately. Many patients come to us because they are coughing, and there are many reasons for a person to cough. If the person has a cough which has certain red flags, for example, they are coughing up blood, or they are having some noises when we do examination, they are having specific noises called crackles in the chest, we have to think of infections or pneumonia. We also may have to think of conditions like heart failure, which causes people to cough, to wheeze, and to be short of breath. So a history is very, very important to guide me to say this person is at high risk of asthma, or this person's cough and wheeze are very unlikely to be asthma, is likely to be something else, for example, heart failure. But remember, having one disease does not mean that one cannot get a second disease. And therefore, for instance, we have patients who have heart failure, but at the same time they have asthma. And by taking a good history, then one is able to decide, is it one disease, is it two diseases, and manage appropriately. As far as asthma treatment is concerned, education to the patient and to the caregivers is very, very important. And the education we give is, one, to reassure the patient, tell them, although asthma is a bad disease, it has a bad rap out there. We know of people who have had it very well controlled, as I have shown previously, and they have lived full lives. So people need not be afraid, but they need to be informed so that they can make the good decisions about their health. Number two is education about the medication that the patient will need to take. There's a lot of fear for good medicine because people may not know everything about these medicines. And as we talk about that, we talk about avoiding triggers. For example, if one has cats in the house or they are painters, we advise them what to do so that they are exposed less to the toxins that are the triggers that are causing attacks in them. We have already noted that people who are obese tend to have worse outcomes in asthma, and therefore weight loss is very important. And when we are talking about weight loss, we must educate the patient about the diet, about exercise. Many patients will be very afraid of doing exercise because they have tried that in the past and they get so short of breath. So we need to take them slowly, even as we educate them about these things. Steroids are the mainstay of treatment for asthma, but there are also other anti-inflammatory medicines. If you remember that cascade I had shown previously, where the main driver of asthma is inflammation, it is therefore very, very important we control inflammation. But of course, this patient is wheezing, and that is due to airway narrowing. Therefore, we may need to give medicines which open up the airway and make it easy for the patient to breathe properly. But I must say that the most important therapy at this point in time in our knowledge in medicine, the most important therapy in asthma is steroid inhalers. Inhalers are very, very important in asthma management. And the reason we use inhalers is because they are able to deliver very low doses of steroids as well as other medicines. And with those low doses of medicines, we are able to achieve control because the medicine is landing where the problem is. So when we use inhalers, we are trying to save the patient from excessive steroid doses. Unfortunately, many people fear inhalers and they feel, hey, I have been given an inhaler, I must be dying. No, that is not the situation. For example, if I may use a calculation, when we use an inhaler like, let's say, beclomethasone, the dose is about 100 micrograms, not milligrams, but micrograms. That is a gram divided 1,000 times, and then you take 100 parts of that. Compared to a tablet, if we are giving this medicine to an adult, that person may need something like 40 milligrams. That means 40,000 micrograms. And if you do the calculation, you'll see that this person is receiving, the one who is using an inhaler is only using 100, while the one using tablets is using 40,000. So by using inhalers, we are able to really cut down the side effects and complications of oral steroids or even syrup steroids. I have noted also, especially in the rural areas, people are getting regular steroid injections. And this is an unfortunate affair because you end up having very severe steroid side effects, such as diabetes, getting excessive body weight, high blood pressure, and bone disease, heart problems. You end up with memory problems, mood problems, ulcers. So when we use this kind of injections or high doses of steroids, either through tablets or injections, we are putting our patients at a disadvantage. It is key that people recognize that inhalers are the safest way to deliver these medicines in persons who have asthma. And there are different gadgets available in the market. The message I would like to pass is that not all inhalers are the same. And when we make our selection, it is based on patient characteristics. For example, there is a patient who will be happy to use the purple one. because of certain characteristics. There's a person who will be happy to use the other one. So even when you get your inhalers, ask the doctor what is in that inhaler. And if your inhaler does not contain a steroid, then that medication for asthma is inadequate. The patient needs to receive a steroid in the inhaler. And there are specific inhalers which are useful, both for the long-term control of asthma, and you use the same inhaler for aborting attacks. When a patient goes somewhere, they're exposed to pain, for example, and they start feeling short of breath, you can use the same inhaler to sort out the acute attack. And this you can discuss with your doctor, and they'll be able to give you the appropriate inhaler. There are people who have problems with inhalers, and what we would recommend is using a gadget as shown. That is an inhaler on the right side with a spacer. The advantage of spacers is that they are easy to use in children. They are easy to use in the infirm, for example, people who have had strokes, or elderly people who are not able to coordinate, people with conditions like Parkinsonism who have problems coordinating. All those people can use this spacer. We also do know that there are people who find it very, very hard to coordinate, not because they have any conditions, but naturally. It's just the same way some people are happy to drive a car, others find it very difficult. So it's the same thing as with inhalers. So if one is unable to use an inhaler directly, then the doctor can consider giving a spacer. And you can even ask the doctor, now that my child is getting an inhaler and I think they are not getting adequate dose, can we use an inhaler with a spacer? And the spacer is useful not just for the regular medication, but also for those patients who have severe acute attacks of asthma. Inhalers, as we have discussed, are small, they are portable, compared, for example, to nebulizers. The current modern inhalers are also able to tell you how many doses are remaining so that you can plan for it. Some of them are propellant free, so we are saving the environment, and they are breath actuated, meaning that when you take a breath is when the medicine leaves the inhaler and gets into your lungs. And they do not really have much preparation time. It's very, very short. It's just opening the inhaler and shaking it, compared to going to look for a spoon, shaking the bottle, and so on. But there are a few things that a doctor needs to assess when they are giving the inhaler to the patient, one of which is that different devices are used differently. So we must educate our patients properly and make sure that every time they come, they show us how they are using the inhaler so that we are sure they are using them properly. Some inhalers are affected by humidity. For example, when the patient is taking the inhaler and the inhaler contains powder, if they blow into the inhaler, then that powder will coalesce and will not flow into the lungs properly. Some of them have only one drug, which may not be adequate for all the circumstances the asthma patient may find themselves in. There are other medicines which one may prescribe for the patient who has asthma, such as nasal sprays when they have rhinitis or sinusitis, antacid medication for those patients who have reflux problems, antihistamines. Indeed, sometimes we may even give medicines for even psychological treatment if we suspect that this patient is not using their medicines because they have some psychological problem. Counseling is also important for all these patients. Then there's the issue of follow-up. Let's assume you've made a diagnosis of your patient, then you're following them up. We follow this kind of cyclical thing where when you come into the office, we'll assess how you are doing. And by assessing, we may need to confirm the diagnosis. We may need to assess the severity of the illness by using a symptom assessment. We also look at the other diseases that one may have. For example, if one is having anxiety or they're having reflux problem or obesity, all these things have to be addressed. Then we assess how well you are using your inhaler and whether you are using it at all. Some people will use the inhaler only when they have a problem, but it is important to know that this is a chronic problem, meaning that it is a long-standing problem. It will disturb the patient in a long term. So even when they come, we assess, is this person using the inhaler? And if so, are they using them properly? Then we discuss with the patient about their circumstances, their social circumstances, their environmental circumstances, and see whether there are things which you can modify. For instance, if one is having a lot of stress, either from work or from family, we can send them to a counselor. If one is having a lot of attacks because they are keeping pets, we can advise to change, or they moved into a new house which has leaky pipes and therefore they have mold. All those things we assess for and we take corrective measures where possible. I've already talked about education and skills training, especially as far as self-assessment using peak flow meters and proper use of inhalers and the other devices that are necessary. And then we educate the patient about what symptoms to look for, the side effects of medication. For instance, if a person has been using an inhaler with a steroid, which has a steroid, and they're having pain when they swallow, we suspect that they may have oral thrush and sort them out appropriately. We may also educate other family members, for example, caregivers, maybe a parent to a child or a grown-up person who has brought their elderly parent. All these things go on when we do our follow-ups. Now, in terms of treatment, we don't give all patients the same medicines. There's something we call titration, depending on how severe a patient's asthma is. So there are those patients who will be advised to use their inhaler only if they have symptoms. But there are those who will be on more than 4 or 5 types of medicines, depending on how severe or how difficult it is to control the asthma in that particular person. And now we will address a few asthma myths. We've already talked about heredity, and we said that not every asthma heredity is a complex thing. Not everyone who lives in a family with a few asthmatics must be asthmatic, and asthma can actually affect a single person within a family. So the issue of heredity in asthma is complex. Asthma can start at any age. I think the oldest person I diagnosed to have asthma was 93 years old. So it can affect really any age group. And remember, many times people have suffered in the past without knowing what this condition is. And when they come in and they have those symptoms that we have talked about, then we have to assess for asthma, irrespective of their age. There is a common belief by many parents that children outgrow asthma. And I find this puts children at a disadvantage, because you may find this child who feels slightly better at the age of 7, 8, and therefore all the medicines are stopped. And then when they go to high school or they're in university, some of them have actually ended up being treated many times for pneumonia. Some are put on TB medication because they are having long-standing cough. So it is important to educate our children, those who have asthma, that they had asthma, and should they see a doctor, they need to mention that they have asthma, so that at least even if the doctor is not thinking about asthma, they can think about it at that time and sort out your child without necessarily putting them through unnecessary tests and treatments. Inhalers, as we have discussed before, deliver very tiny quantities of medicines. They do not necessarily imply that the patient is sicker than that person who is using tablets or using syrups and other type of medication. Asthma is an allergic condition, and therefore, but it is a special allergy. And therefore, medicines like antibiotics have no role. Some people use warm water, honey, different types of herbs. Most of these medicines will not affect the trajectory of asthma and may actually delay the proper diagnosis and proper treatment of asthma. When one is diagnosed to have asthma, that person remains an asthmatic for life. But they may not necessarily suffer asthma symptoms every day. And this is because asthma has a characteristic of periodicity. Sometimes it will be disturbing, sometimes it will keep quiet. It disturbs again for whatever reason, whether it's exposure to triggers or exposure to things like cold air. Sometimes you may not even know why it starts, and then it will keep quiet. When it keeps quiet, it is not that it has been cured. It has just kept quiet. And we do know that at some point in the future, it may come back. And when it comes back, it is important to remember that one is asthmatic and to inform the doctor so that the proper diagnosis is made. Many people believe asthma is a mild disease, doesn't cause any harm, and therefore they may even neglect their medication. But we do know that asthma kills. For example, in 2019 in this country, we had about 765 people who were registered to have died of asthma. So it actually can kill and therefore needs to be treated properly. And with that, I think I come to the end of my presentation. Thank you very much, and I would now welcome questions.
Thank you so much, Daktari. Wow, that was very informative and elaborative. Right now, I'll go straight to questions in the chat box. Now, first question is from Joyce Muia, and she asks, what is the relationship between allergies and asthma?
Thank you, Joyce. The relationship is such that asthma strictly is what we would call type 2 allergic conditions. The difference between asthma and the usual allergies that people have, where they have a running nose or maybe skin allergy, is that the cells which mediate asthma have long-term memory. And therefore, if one has asthma now, the body will remember 10 years, 20 years down the line what that person was reacting to. And if they are re-exposed, then they will need to remember they had asthma. And secondly, I showed a very complex interaction of, if you allow me, in this, in this, on the right side, you can see that there are very many cells which are involved in asthma compared to the usual straightforward allergy. And therefore, even when we manage patients, we have to put this into perspective, that this is not a simple allergy. This is an allergy involving multiple cells, multiple chemicals, and therefore, when we give the medication, it has to be able to take care of all that spectrum of pathology. Thank you.
Thank you, Daktari. That also answers a second question, which she was asking whether allergies mean someone has asthma. The next question is from Jacqueline Rotich, and she asks, eczema in toddlers cause asthma?
Okay, I think we have also alluded to that, in that asthma does not just affect the airway. If asthma is caused by that interaction of all those cells that I've shown there, and those cells are floating in blood, they can cause a change in different parts of the body. And the commonly affected parts of the body are skin, eyes, nose, throat, the pharynx, or that's the throat, the sinuses, as well as the airway and the food pipe. Not all allergies are asthma. And similarly, but because asthma is an allergic condition, you have many of the manifestations of allergy. So to put it simply, many children who get eczema also are predisposed to asthma. Not all of them develop asthma, but a good proportion develop asthma.
Thank you, Daktari.
Thanks.
Ruth Mata also asks, what do you do to a child who wheezes almost every night and gets dry cough, especially at night?
Yeah, that child most likely has asthma. And therefore, what we need to do is take that child to a pediatrician or to a doctor. And as I have said before, the treatment will need to include a steroid. Many people are afraid of giving their children steroids, but we have had research done which showed that if you follow up children with poorly controlled asthma, and children with asthma which is well controlled, and you follow them up, those children who have poorly controlled asthma tend to get stunted compared to those who use adequate amounts of steroids for disease control. So do not be afraid of steroid inhalers, but discuss with your doctor so that the right doses and the right frequency can be prescribed for your child. Thank you.
Thank you. We also have a question from Felista Ariao, and she asks, is asthma the same as allergic rhinitis? She elaborates and also says that when she was young, she was told she has rhinitis, but later when she was in university, she was told she has asthma and was given inhalers.
Thank you, Felista. And that illustrates what I was talking about, that asthma does not just affect the chest. Asthma changes over time. Allergic rhinitis is strictly not asthma, but it is one of those diseases which can predate asthma and are related to asthma. I may have shown that picture somewhere. This. Thank you.
Thank you. Kezia Korid asks, why and how do foods trigger asthma?
When one has tendency to asthma, it means that their body is reacting excessively to certain things which other people's immune systems ignore. And if we look at this picture, you can see something on the right upper corner reading, or is it left, depending on how you look at it, reading antigen. Antigen is a component of food or something found in the environment, like dust or protein or certain chemicals like carbonates and so on. And when these get into our system, they trigger that cascade of reactions, and that can end up with asthma symptoms if you follow that chart downwards. So when a person eats a certain food to which they are sensitized or their body is excessively sensitive to, that food, once digested, goes into the system, goes into the system, and the immune system detects those particles. And those particles, if I may use that word, trigger an asthmatic reaction through that cascade I've shown there.
Asante, Daktari. Ruth Martha also asked, what is an asthma attack? Is wheezing in the night an attack?
Yes. Now, asthma attacks also vary. The thing to take about asthma is that asthma is a disease of variables or variability. An asthma attack can be very mild to extremely severe or life-threatening. And when one comes for an assessment, we take a history, including asking whether they are coughing, they are wheezing, because those will tell us that this person has poorly controlled asthma. Wheeze is one of the symptoms of an asthma attack. But for most people, an asthma attack is that one which is so bad that it takes you to hospital. But there are people who have asthma attacks which are persistent. They are not having such severe symptoms as to stop running their lives, but there are symptoms which are irritating, which are inhibiting them from achieving their full potential. So yes, if one is coughing at night and wheezing, those are asthma attacks.
Asante. Petronila asks, if one has repeated chest congestion, does that mean you are asthmatic?
Chest congestion can be due to many things. As we have discussed, I talked about mimics of asthma, implying that there are many things that can cause chest congestion. Asthma is the commonest. If you remember the data I used, we find that up to 10 or even more % of the population in this country has asthma. So if someone tells me they have chest congestion, very quickly I must think about asthma. Take a history to find out whether really it fits or there's something else that can explain that congestion. But yes, that person really needs to be assessed for asthma. It's likely.
Oh, thank you, Daktari. John Minor asks, is acute bronchitis related to asthma?
Acute bronchitis is basically due to two things. One is allergic reactions, and number two, infections. And the way you can tell is frequently in a person who has acute bronchitis due to infection, they'll have other things like fever, while generally in patients who have allergic bronchitis, generally they will not have fever. And that's how we distinguish these two easily. Now, many people who have asthma have been deemed to have, or rather have been told that they have acute bronchitis. And the way to distinguish between acute bronchitis and asthma is that acute bronchitis usually is a one-off condition, but asthma presents recurrently. So if someone comes to me and tells me last week I had a cold and now I can't breathe, I'm coughing, I'm wheezing, and this is the first time ever in their life, or the last time they had a similar thing was 10, 15 years ago, then most likely that person has a bronchitis of sorts. While the other person who comes and tells me every July I get acute bronchitis, nikienda mahali where there is some dust, I get acute bronchitis, then I'll start saying, no. That likely is not acute bronchitis, but it's likely to be a recurrent problem, and the most likely diagnosis is asthma. So a history helps us distinguish between these things.
Thank you. Jane Biari asks, what precautions should asthmatic people take during the current COVID-19 pandemic to avoid infection? This is related to another question that is on YouTube by Catherine Ryungu. She also asks, is asthma one of the post-COVID complications?
Good questions. Now, research has shown that people who have asthma and are well controlled and they get COVID, they tend to do better than those people who do not have asthma. Therefore, I would encourage anyone who has asthma to get it properly controlled, because if, God forbid, you get COVID, you are likely to do very well. Number two, we do know that people who have asthma, which is poorly controlled, then they get COVID, they tend to do badly. So another incentive for one to get the asthma properly controlled. Number three, asthma does not protect one from COVID. Therefore, the usual things that we are being educated about, number one, hand washing or sanitizing, making sure we avoid crowds, and sometimes these crowds are family, use of masks and social distancing. All those are key things. Whether one is asthmatic or not, those are things that we should practice all the time to avoid COVID. Please repeat the second question.
The question is asthma one of the post-COVID complications?
What we know now is that COVID infection is causing a lot of lung damage. And as late as 2 weeks ago, there was a major article written, and it's actually reflecting what we are seeing in our practices, that there is a small group of patients who are getting COVID-19. And after they have cleared the COVID-19, they come in 4 months, 6 months, 8 months down the line with typical asthma symptoms. They are coughing, they are wheezing, they are having shortness of breath, and you do a CT scan or a chest X-ray and their lungs are normal. And these problems recur and they behave exactly as asthma. And by definition, they are fitting the definition of asthma. And therefore, what one is asking is it the COVID that has triggered asthma? And indeed, some people believe that COVID itself can cause asthma. Or is it a person who had asthma, was not diagnosed, but now got an excessively inflammatory condition called COVID, and therefore their journey has progressed and now they are manifesting asthma? So those are questions which we do not have answers to, but indeed we do know that some people are healing from COVID, but ending up with new onset asthma. So that's a very, very good question.
Asante Daktari. Lucy Waithaka asks, how do you wean off usage of inhalers over time, or do you have to use it in your lifetime?
Asthma is a disease which will disturb you, keep quiet, disturb you, keep quiet. And when we treat patients, we recognize that. And we do know that sometimes when you treat patients well, the asthma symptoms may disappear for months or even for years. And so what we do, we review patients every 2 to 3 months. As and when they improve, we slowly wean them off their medicine. For example, let's say a person was using a dose of 400 micrograms of a certain drug, morning and evening. After 3 months, they have had no symptoms. They can come down to 200. After 3 months, Why did that person talk about COVID? Then I start coughing. So after another 3 months, 2 to 3 months, if the person is still doing very well, we reduce the dose again. And a time will come when we'll be using very low doses that you tell the person, stop. But even when you tell them to stop, your doctor has asthma actually, and maybe I'm reacting to something. So even when you tell the patient to stop, we would usually give them a dose of medicine to stay with them, because you cannot tell the day or the night when they'll start wheezing again. So we'll give a small dose of medicine. Should they get symptoms, they start using that medicine even as they plan to see us. Thank you.
Thank you. Then we have a question from Iron Gift, who says that she realized that they could be asthmatic after getting shortness of breath when they entered a room that was cleaned with the concentrated. But currently she suffers from a sore throat and is asking how can she relieve herself of that sore throat.
Yeah, we would need to take a bit of history to find out when the person was exposed to that room with an irritant. But, you know, a history would be very, very important, because the fact that one has asthma does not mean they cannot get sore throats due to other things. And there are people who do not have asthma, but when they go in certain environments, for example, if you went to certain industries, they are dealing with organic compounds, one may start having a wheeze, not because they are asthmatic, but because their body is reacting to those chemicals. So a history would be very, very important so that you can get the nitty-gritties of that lady's concern.
Asante. Thank you. And then we have Val, who is appreciating the talk, and she now understands that why she feels worse during that time of the month. She said she stopped using Symbicort and the wheeze disappeared, but frequently she's having chest pains and is asking, does she resume the Symbicort use?
Chest pain is one of the commonest asthma symptoms. And therefore, if one is still having those symptoms, it implies that there is inflammation going on. The medicine she's using is very good for controlling inflammation. So I would strongly advise her to continue with it, but to make an arrangement to see her doctor so that a proper assessment and advice on when to stop, if at all she need to stop that dawa, can be made.
Asante. We have another question from Grace Kabue, who asks, are asthma tests readily available in most health facilities?
Are asthma what? Tests or medicines? Tests.
Yes.
Yes, most good hospitals will have a facility to do spirometry as well as peak flow rate. But remember, many doctors may not even know how to interpret them. So what I would suggest, let her see a pulmonologist. Once a spirometry is done and she would like to continue with her usual doctor, the pulmonologist can give that report with an interpretation and recommendations to her usual doctor.
Okay. Thank you. We have another question from Joyce Muya, and she's asking, what are the first aid or home remedies that one can use for asthmatic attacks?
If one has asthma, the way to treat asthma is by using inhalers. So the first aid is to have inhalers, the appropriate inhalers at home. If a child, for example, is developing difficulty in breathing and their inhalers are not working, one can use this gadget to help relieve that person. This I would consider a first aid kit for patients who are having difficulty in breathing and they are known to have asthma. But really, if one is known to have asthma, they should have the appropriate inhalers. And sometimes we talk about nebulizers. These are machines which blow medicine into a patient, which they can use as first aid at home. Home remedies, as I had alluded to earlier, as is ideal.
Asante. Jacqueline Rotich asked the questions, does one need to see a specialist doctor for diagnosis? I guess you had already answered this when you said that she needs to see a pulmonologist.
But not necessarily. We have very many good doctors out there who are diagnosing asthma. We have an organization in Kenya called Respiratory Society of Kenya. This is an organization for pulmonary specialists, and we are actually running courses to train people, even mashinani, how to make proper asthma diagnosis. And you know, now it is much easier with these webinars. We can talk, like tomorrow I'm giving a talk to maybe about 400 clinical officers. So eventually this information will go to different parts of this country, and you may not need to see a specialist. So long as the clinical people do have the information, then one can get as good treatment there as elsewhere. Now, another thing is the chart that I showed, that there is a huge amount of management which can be done by any doctor in this country. It's only when we go to step 4 and step 5 that we would request that that person is sent to a specialist, even if it is a one-off, so that the disease can be brought under control, and then the specialist can review that patient once or twice a year. The other physicians or clinical officers are generally able to manage that. And you see now with telemedicine, we are able to even advise people in all the corners of this country who have these conditions. And we actually do invite people to ask these questions even over the phone or email or other methods.
Thank you. Anne Kaloki asks, how do you manage allergies in children?
How do you manage what?
Allergies.
Oh, okay. Generally, how we deal with allergies, number one, identify what is causing the reaction. If it is a type of food or a type of exposure, for example, to grass of different kinds. After identifying the type of reaction, then two things. One, you manage symptoms. If a patient is itching a lot, then you give something to reduce the itch. If a person is having a running nose, something to sort out the running nose. And avoidance. Avoidance is where, when we identify what is causing the problem, we avoid it. For example, there are people who will develop allergic reactions after eating nuts. Now, nuts are not very, it's not a must that one eats nuts. And therefore, you can advise that person, please avoid nuts. And you find that their symptoms go, they may not even require any treatment, or they are reacting to milk or reacting to pawpaw or things like those. If you identify the cause, you can advise what to avoid. But some things are difficult to do. For instance, if one reacts to pollen, when it is pollen season, I mean, unless you go to another part of the country where there is no pollen, pollen itakupata tu. So in that case, if it is just simple, straightforward allergy, then we can use antihistamines in various forms, whether they are eye drops or nose drops or tablets, depending on the site of the body that is affected.
Asante. In the interest of time, I will just ask the final question. Frederick Shamola says that his son was once told that he has something like asthma, but not asthma, and given 2 inhalers, Budicort plus another one. And he says the child has not used them for more than 4 years. Does he really have asthma? I guess he's asking whether there could have been a misdiagnosis.
Yeah, so it is sometimes a failure on our part as clinicians, one, not to tell people exactly what is ailing them, because now that creates confusion. But especially in children, where we may not be able to do some of these tests like the spirometry, it is sometimes difficult to tell whether this is asthma or an airway infection. You remember we talked about bronchitis. In children, the even smaller airways called bronchioles can be affected, and that can lead to a condition very similar to asthma called bronchiolitis. And the treatment for bronchiolitis in most cases is use of inhalers and steroids. So one may end up being very confused. Was this asthma or not asthma? And if the child has stayed without asthma for 4 years, or without the attacks for 4 years, it does not mean that that person, if they indeed had asthma, it will not come back. Because asthma, by behavior, is a disease which comes on, goes away, comes on, goes away, and it may go away for many years. I have had patients who had asthma in the 50s, and now they are presenting in their 70s with pure old-fashioned asthma. And throughout their lives, they have never had asthma symptoms. But because that's the way asthma behaves, we are not surprised. We expect it to behave like that. Thank you.
Thank you, Sana Daktari. I truly appreciate all the questions that have been asked from the chat box, and that due to the time factor, we request that you may reach the doctor directly. Kindly, Daktari, please let them know where they can contact you and see you.
Okay. My office is in Doctor's Park. This is on 3rd Parklands Avenue, just next to the Aga Khan and Medihill hospitals. I am on 5th floor, Block A. And if you'd like, I can give my phone number. The office phone number is 07 999 366 99. 07 999 366 99.
Asante sana Daktari. I've also put the same number on the chat box so we can be able to reach Daktari directly. I would like again to appreciate the participants for the very interactive question and answer session. We truly appreciate you taking your time to log in and learn something new or be reminded of something that you had already known from before. Again, Daktari nasema asante. We also thank our sign language interpreter, Nelly Langat. Thank you so much for you being able to deliver the information to our hearing impaired clients. I would also like to thank for all of those who are in part able to help us plan for this webinar. That is our marketing team, Mary Kiilu, just to mention a few, Godfrey Kiragu, Christine Mwiti, and last but not least, our head of Britam Health, David Obonyo. With that, have yourself a good afternoon, and thank you again.
Thank you.